hope that it's instructive and useful, and I'd like to thank the panelists for taking the time to actually be a part of this. Thanks.
All right. Thank you so much for being here, and thank you, Mike Howe and Wilder Foundation for having us all here today. My name is Sarah Greenfield. You've probably gotten a few emails from me. I'm the healthcare program manager at Take Action Minnesota. And some of you know us, some of you don't. Take Action unites the power of individuals and organizations to impact the issues that affect their communities and their lives. And on healthcare, we've worked alongside many of you over many years to expand access to healthcare, especially, always from the consumer perspective, or as we like to call consumers, people. And I'm excited, I'm actually very excited to have so many of you here today representing so many diverse organizations from around the state, because it's the folks in this room and other folks like you who are going to actually translate that expanded access, the idea of it, into a reality for people around Minnesota. So I really am glad to have so many people here. I'm going to be speaking about the Affordable Care Act. It also goes by Patient Protection and Affordable Care Act, Obamacare, and I like to call it the ACA because it's short. And it's a large bill, and it has a lot of, or it was a large bill, it's a big law. It addresses a lot of things. I'm not going to get into half of them. What I'm trying to address today, and I hope I can do, is to focus on a few key features of the law as a context for understanding both the need and the opportunity that the Affordable Care Act and healthcare reform create for changes and growth in outreach and enrollment assistance. So, the Affordable Care Act changes healthcare in some big ways. It changes both private and public healthcare, so public healthcare programs and private insurance. It changes who is eligible for what kind of public healthcare, adds a new category of private health insurance subsidies. It changes how people will apply and enroll in those programs and in private insurance, and it creates some new categories of helpers. I'm going to be I think the way that those changes roll out in the Affordable Care Act, as I'll talk about over the next 20 minutes or so, really, again, make it both more necessary for a lot of us to get enrolled, engaged in helping people enroll. And also it's going to make it more possible for organizations that may not even have been working in healthcare or healthcare enrollment before to do that. So I'll take a few questions at the end, but also want to encourage you to use the form that Mike Howe pointed out to not only give us feedback on these presentations today, but to write down any questions that we don't get to, because we've got a lot of people. It's a big topic, and I know that there will be remaining questions at the end. So let's start with why. Why healthcare reform? A big goal of the ACA is to expand coverage and expand access to healthcare for uninsured and underinsured people. If we look at Minnesota, we have about 9% rate of uninsurance, which is considered low, but we know that it's too high and that it's been rising. That 9% rate is sort of at any given point in time, but over the course of a year, over 12% of our population is uninsured at some point. We know we have high disparities in healthcare overall, and health disparities, and in uninsurance in particular. People of color and Native Americans make up about 13% of Minnesota's population and have more than twice that rate of, or more than twice that percentage of our uninsured population. And uninsurance really only tells half the story, because a lot of people, maybe some people in this room, certainly people that we know, have insurance coverage but it doesn't really cover the costs of their care, or they're one illness away from serious financial implications from their healthcare needs. And in Minnesota, one statistics that references that, though it certainly doesn't cover the whole picture, is that we have about twice the national average of folks in high deductible health plans. So I like to talk about how the law addresses this issue as a sort of set of interlocking features. In Minnesota, we expect implementation of the Affordable Care Act to get coverage for around 300,000 people. There are some variables that are still in play that we'll be talking about as we go through the rest of the conversation today. But between 300, 340,000 people who are currently uninsured are expected to get coverage. And then again, as I mentioned, many more people who have insurance will be able to access better coverage, we hope. And it does this through this set of sort of interlocking features: insurance reforms, an individual mandate, an expansion of Medicaid, and in Minnesota, an expansion of Minnesota Care, subsidies for private insurance, and the state insurance marketplace, or MNsure, that we'll hear about shortly. So I want to spend just a few minutes talking about each of these pieces. Oh, and first making the health coverage blink. That's very important. Highlighting it. So some of the changes in health insurance under the Affordable Care Act, these are really some of the more better known pieces of healthcare reform, and certainly the more popular ones. So you could be denied or charged more for having a pre-existing condition, certainly for the vast majority of pre-existing conditions. This is called guaranteed issue. It means that in the past, where even for any price, you might not be able to buy insurance if you had certain health conditions, and certainly would be charged much higher. So that is going to mean that a lot more people who are shut out of the private insurance market are going to be able to get in. There need to be easier to understand labels for insurance plans. It's not quite as simple as the bottles with a USRDA on it or something, but it's going in that direction so that you can compare apples to apples. There will be no lifetime or annual limits on most care, on what's called essential benefits. Coverage for preventative care, and again, these are all defined terms, so it's not everything that could be preventative care, but lots of things that people currently put off because of either not having insurance or because of the additional copay or deductible will be covered just by having insurance. And of course, children can now stay on their parents' insurance long past the time when they're children into young adulthood. So those insurance reforms really lead to this question of the individual mandate. The danger with particularly the guaranteed issue, this no more denials for pre-existing conditions, is that people might wait to get covered until they're sick. And so with the Affordable Care Act, along with that guaranteed issue, came the concept of an individual mandate. And so this is a requirement that most people carry health coverage, whether public or private. And that if they don't, most people would be required to pay a fine. So let's talk about how the individual mandate works and who that affects. The fine begins in 2014. It's $95. It does rise to $695 or up to 2.5% of your taxable income by 2016, and then it's geared to inflation beyond that. The idea, again, is to encourage that people get coverage before they're ill. The reality is, and this is based on study by the Urban Institute and Robert Wood Johnson Foundation, there's not an expectation that a very large percentage of the population would face this fine, and we'll talk a little bit about who's exempted, but they estimate that maybe 6% of the population will need to choose to either newly purchase coverage, if they're not already covered, or face paying a fine if they don't. And that leaves about 33% of the under 65 population is exempt, and many of those are already covered. So that's why we get to that small percentage. So some of the exemptions from the mandate. If you're below the tax filing threshold, so the very low income, again, that population should be eligible for Medicaid, but would not face a fine if they chose not to enroll. Undocumented immigrants who are also not allowed to use the exchange even with their own dollars, which cuts out a significant portion of people, but then they are also not, they're not required to be covered. people who've been uninsured for fewer than 3 months. So this is just sort of recognizing that people go in and out of insurance, and you're not fined the day that you lose one source of coverage. Native Americans, and then there are certain exemptions that you can apply for either economic hardship or religious objection. So there will be people who can get exempt from the mandate. But I think for most of the people in this room, the focus is less on who isn't subject to the individual mandate than on really how do we actually get people access to the care that they need. And I think a lot of us have experience in working with folks that the large barrier for people in getting coverage is often not that they don't want it and are opposed to it, though that certainly exists, but that they can't afford it. And so, again, with these sort of interlocking reforms, we have insurance reforms, we're requiring people to get insurance, but then we need to make it more affordable. And so the Affordable Care Act addresses that issue in two primary ways. And again, there are some other features, but these are kind of the big ones. So expansion of Medicaid and Minnesota Care, and then these subsidies for private insurance. So Medicaid expansion. This goes into effect on January 1st of 2014, the full Medicaid expansion. Minnesota has already done early Medicaid expansion last year. In Minnesota, this will cover parents, young adults, and adults without children up to 138% of the federal poverty level. I think a lot of people in this room are very used to talking in percentages of the federal poverty level. For those of you who aren't, I apologize. It's sort of a lot of numbers that get thrown around, but that translates to about an income of $31,000 for a family of four. Actually, it's about $15,500, I think, for an individual, and that scales up a little bit every year. So we're really talking about moving Medicaid right up to about the annual wage of, say, a full-time minimum wage employee at our current minimum wage. And then it'll go even further for pregnant women and children. In 2014, that'll be moving up to 275% of the federal poverty level. So another big change, not just those income levels, but also the asset test. So a barrier for some people, and in Minnesota, we've already done this for Medicaid, but this will also go into effect for Minnesota Care. So the non-MAGI population, the low-income, non-elderly adults, eligibility will no longer be subject to a test or an asset limit. It'll just be based on income. So that both really simplifies the application process and also will include some additional people. And the total there with that Medicaid expansion, this is counting both people who are currently uninsured, people who are subject to this early Medicaid expansion, and folks who are currently on Minnesota Care that will now be absorbed into Medicaid, comes to, we think, about 145,000 people newly covered on Medicaid in Minnesota. So moving on to Minnesota Care. Minnesota is one of a handful of states that has had historically a program that goes above Medicaid and offers coverage for both families and for adults without children who are low income and working. And Minnesota Care has been a very strong, successful program for 20 years. It does have some limitations. It's had a $10,000 hospital cap, which if any of you had to go to the hospital for anything recently, runs out pretty quick. And there's been a waiting period required in order to enroll. So you need to be uninsured for a certain period of time before you can enroll. So those are among the things that will change through the Affordable Care Act as we move forward with Minnesota Care next year. The hospital cap goes away. There's no period of uninsurance required because you can't really require people to be uninsured when you're also requiring them to be insured. There's no more asset limit, so we're extending that from Medicaid into Minnesota Care. And these details are all subject to things that are going on right now at our state capitol and the finalizing of the omnibus bill. So there's all of the proposals right now from the Senate, the House, and the governor all include Minnesota Care, and they all have the premium levels either the same as they currently are or lower, but we're not sure exactly where that'll land. And some of the population projections you see here will vary depending on where those premium levels land, of how many people we think will get covered. But it's worth noting that Minnesota Care in 2014 will only go up to 200% of the federal poverty level. So while we're expanding in a lot of ways, it is sort of restricting in that way. There's a population above 200% that had moved on to what's called the Healthy Choice Contribution Program last year, and that portion of Minnesota Care will no longer be in Minnesota Care and will now be, as we understand from the bill as it is, will be on the exchange, which I'll talk about in a few more slides of what that'll look like. But they'll get tax subsidies and purchase private insurance through the exchange. So that remaining portion between above Medicaid, so 138% of federal poverty level, up to 200%, is expected to increase considerably what our current coverage rates are in Minnesota Care and go up to somewhere between 150 and 200,000 people enrolled in that program. And again, most of these enrollment projections are looking out a couple years, like by 2016. So one of the largest, kind of most fundamental changes, I would say, that the Affordable Care Act brought out is not just the expansion of these public programs, but initiating for the first time a nationwide program of federal subsidies, so public money subsidizing private insurance. Subsidies are they're tax credits, so they sometimes are called subsidies, now more often called tax credits. They're based on a sliding scale, so it's not a one-sentence deal to tell you what your subsidy will be, but I'll give some examples shortly, and MNsure has a great calculator tool that you can use for yourself or folks that you're helping. So they're tax credits, they're based on a sliding scale depending on income, so that you can only pay up to a certain % of your income for a sort of good middle-level standard plan, and beyond that, if the cost is more than that, then you would get a tax subsidy for the rest. And you can choose to get those tax subsidies in advance or to have them actually, tax credits, or to get them actually as a tax credit at the end of the year. Any of you who choose to become consumer assistance partners are going to get substantial training about the implications of that decision for people, I'm sure, about whether or not they take that tax credit up front or after, and if their income changes over the course of the year. So you can kind of imagine there are some decisions people have to make about that risk, but it is for the first time a chance for people to have an affordability limit, or a standard of what's affordable, and get assistance beyond that for them to carry private insurance. So for people between 200-400% of the federal poverty level, there are two kinds of credits. One is the premium assistance tax credit, and that sets on what they consider an affordable premium for people, and that's a little over 6 to 9.5% of their income, depending on where they fall in that federal poverty level. And then there's a second credit, the cost-sharing assistance, that pays the difference if that person's or family's total annual out-of-pocket costs exceed certain levels. $3,000 for an individual at the bottom of that scale, and $6,000 for individuals who are above 400%. So this, unlike the premium assistance, this cost-sharing assistance is actually for all of the plans that will be offered on the exchange on MNsure, and so it goes above 400% of the federal poverty level. So some examples of what that looks like. For a family of two that is earning about $32,000 a year, which is about 200% of the federal poverty level, the maximum cost that they should have to pay for what's called the benchmark plan. To go into all sorts of things of describing what the benchmark plan is, but it's considered sort of a mid-level quality plan that covers all of the sort of preventative care and essential benefits that we've discussed. That will be about $174 a month for them, and any cost above that for the premium they would be eligible for a tax credit for. And their maximum out-of-pocket costs, so those are things like the deductibles, co-pays for covered benefits, would be $6,000 for a year. And for a family of five, earning about $83,000 a year, so 300% of the federal poverty level, that goes up to $657 a month for the whole family, and a maximum out-of-pocket cost of about $8,000. Now, some of you may be thinking, wow, that's really great, and some of you may be thinking that's a lot of money. People at that level can't afford it. Kind of depends on what your insurance is like now and what you're paying. Certainly, there are a lot of advocates that, probably many of you in this room, that work to get a lower affordability threshold so that assistance would kick in sooner. But it's important to note that there are no guarantees right now for families in these categories, and often no assistance for them. And so this is a step forward in that sense that may bring a lot more people into private insurance. And again, that MNsure.org has a good calculator if you want to look at some examples of other profiles. So this, just to kind of put those last handful of slides into perspective, and again, these cutoffs are about adults, so this is not reflecting children and families and pregnant women. But just to show that it's a spectrum of coverage. One picks up where the other drops off, a spectrum of assistance, and we have Medicaid, then Minnesota Care, and then private assistance or tax credits for private insurance up to $400. And beyond that, people can still purchase on the exchange, but there wouldn't be financial assistance for that. So we've talked about the insurance reforms, the mandate, and these affordability measures. All of this is going to be operated through what I keep referring to and what many of you know about the exchange or MNsure in Minnesota. Bob and Mary are going to get into a lot more details. I'm sorry, not Bob and Mary now. Mary and David, who've come here from MNsure in a little while, will get into a lot more details about that and about the specific consumer assistance roles. But I want to explain just the basic idea of this marketplace and of the exchange. So Health Insurance Exchange is, at its core, a new web-based marketplace for health coverage. It's going to have a single streamlined application for Medicaid, Minnesota Care, and private insurance. That's part of what is sometimes referred to as no wrong door. That's not the entirety of no wrong door, but the idea being that you don't have to go to one place, fill out one application to find out if you qualify for Medicaid. First of all, to even think, maybe I qualify for Medicaid, and to go fill that out. You go, you put in your information, your household size, your income, and it's going to come back and tell you you qualify for some level of public health care or for assistance for private insurance all in one place. It's going to be set up in such a way to help you compare apples to apples, and that is, the exchange, MNsure, is the only place where you will be able to get purchase plans that qualify for the federal tax credits. So there's a real incentive for people in that population range above Minnesota Care and through 400% of federal poverty level to use MNsure to purchase their insurance, and it's the plans that are going to be called qualified health plans, the plans that are sold on the exchange that they'll be able to get those tax credits for. Enrollment in exchanges begins on October 1st of this year, very soon, which is I think why we have a really full room here. And the coverage of those plans will begin as soon as January 1st, 2014. So who's going to use Minnesota's exchange? I've heard 1.3, 1.2 million, around that number of Minnesotans are projected to be enrolled by 2016. About a third of those, again around 300,000, are projected to be people who currently don't have insurance. They're individuals and families who don't have employer-sponsored coverage or whose employer-sponsored coverage is considered unaffordable. And again, that's tied back to those numbers I was referencing before. So if your employer offers insurance that costs more than 9.5% of your income for your individual plan, you could opt to not take that and to instead get a tax subsidy or tax credit on the exchange. Unfortunately, there is a caveat to that, that if your coverage, say, costs 8% of your income, but your employer offers a family plan, and say the family plan costs 20% of your income, that still means that your family is not eligible then to go purchase coverage on the, they can purchase coverage on the exchange, they're not eligible for tax credits anymore. So that was a big loss. I think it's a big hole in terms of coverage, and something that we'll have to look at as a state, how that impacts our coverage outcomes through the exchange. But again, for individuals, if they have employer coverage, probably nothing changes for you unless it's very expensive, and you may then be able to get a plan on the exchange instead. And the other people, a large group of folks who might be using the exchange, in addition to folks enrolled in public programs, are going to be small businesses. So from 2014 to 2016, those are businesses with 50 or fewer employees. And then in 2016, that goes up to businesses with 100 or fewer employees. That may, and they may purchase plans for their business on the exchange. So this is what it's projected to look like. These numbers come from the Gruber-Gorman analysis and presentation by Minnesota's exchange, actually. So a lot of the folks, when we talk about that 1.2, 1.3 million, a large percentage of those are expected to be Medicaid enrollees and Minnesota Care. And then we've got folks who are going to be in the individual market, either with or without tax credits. So again, some people above that 400% of federal poverty level may still find the selection better or the process better of looking on the exchange. And then the very light square you can't see is the enrollees in small business plans. So in summarizing, I just want to say that, again, these opportunities for better healthcare that are going to be out there for people, combined with the fact of the individual mandate and the possibility of a fine, and this new enrollment system that, as you'll hear much more about, actually should make things quite a bit simpler to enroll, means that a lot more people are going to need help very soon, and that help, we think, will be easier to deliver than it has been in the past, but also very important to deliver for organizations like yours. And that's why we're here today. So as I said, we're going to hear directly from MNsure staff about the specific roles and ways that people can help in a minute, but I'm certainly happy to take a couple of questions if there are any related to eligibility and enrollment in the Affordable Care Act. And
wow. Minnesota nice.
Hi. That was, yeah, very Minnesota nice. I just had a question about, so it said undocumented immigrants aren't required by the mandate. Do we know if immigrants who are not permanent residents, who are, for example, here on visitors' visas, students, tourists, if they're eligible to participate in the exchange?
So my understanding is that people who are sort of who are residents or in the citizenship process are subject to the mandate. I could not answer specifically about folks on a sort of a shorter term visa. I don't know if somebody from MNsure knows that answer, or it's certainly something I could try to get back to you on.
I'm just wondering about those seniors that are lower income that are buying supplemental health care plans that are in the $300 range, and they're like have $1,500 a month coming from Social Security, where they fit in this.
So, Seth, do you want to say it?
Yeah, I don't know that, and I think the MNsure people can back it up, but for people Medicare eligible, this isn't going to apply to them. It wouldn't apply to supplemental care plans.
Seth from AARP. So the tax credits certainly do not. I don't know if people have the option, or at least it's my understanding that tax credits would not apply to somebody in that Medicare eligible. I don't know, though, if people might have the option of purchasing with their own dollars if they found a more affordable supplemental plan on the exchange. But the qualified health plans on the exchange are required to cover a comprehensive set of benefits. So my understanding so far is that would not be an option for them. I do think there's a lot of thinking in the longer term once the incredibly challenging and chaotic first couple years and this year really get off the ground of how will the exchange be expanded and what will be offered there. I certainly know there's conversation about an intent to offer other benefits so that, again, talking about the under Medicare population, but when people are applying and finding out if they qualify for Minnesota Care or Medicaid, why not also tell them the other range of benefits they qualify for? So I certainly think that other expansions are also possible, but it's a lot to just start right now.
Let's go here.
And we'll just take, I think, these two questions and one more and then wrap up.
My question is around, you say that Medicaid is also going to be part of the exchange, and my question is around people that have a certified disability and are qualifying for it that way. Is it going to be through the exchange? I have no clue, no idea, and I would like some clarity.
You asked me that question once before. I'm a little clearer, but not 100%. I'll ask the MNsure folks to seal that up, but it's my understanding that currently is not planned to be enrolled through the exchange. That it's am I right in saying that's a non-Magi population? So it's Magi populations that I think are planned to be enrolled through the exchange at this point.
Will undocumented people be eligible for care?
To the same extent that they are now. So some emergency room care, sometimes, there are some programs, emergency medical care, which certainly has been challenged. that can cover certain things, but I think it's a big question, and probably a question for a lot of folks in this room is what are the sort of parallel systems of care delivery and the safety net that are still really going to be needed.
But my question is about folks who become unemployed. So beyond, say, that 3-month period, so they may still be on unemployment insurance, but they've lost their health care, they're unemployed. When are they going to, how will they qualify? When will income be? Will it be a year back? How will you calculate that for folks like that? Do we know?
So I do know that in addition to the open enrollment period, which again for the first year is 6 months and then in subsequent years is just 3 months, at life changes, people are eligible to enroll. And so becoming unemployed, divorce, marriage, those things are included in life changes. I think it's challenging to predict exactly how the income verification, how that plays out, both when people lose a job, get a new job. And so I'm hoping that maybe Minshore can answer that a little bit more, or that's something that will, that I can't answer at the moment.